Thank you, everyone. We're just waiting for two of our panelists to come up to the front. Okay, thank you, everybody. We're going to go ahead and get started with our second panel of the morning. And this next panel is designed to provide a boots on the ground perspective on some of the work that is happening in states and localities to be able to advance the promotion of children's behavioral health. And we have 4 panelists who are with us today. I know you can only see 3 of them right now. But I have it on good authority that the 4th will be coming. As a minor adjustment to your agenda, unfortunately, Maria Gomez is not able to join us today, so that is one adjustment to our agenda, but the other 4 panelists will be here with us today. And each of the panelists are going to be spending a few minutes highlighting the work that they're doing in their respective state or locality to help bring about some of these innovative activities for promoting children's behavioral health and talk about what that looks like within their area. And then the remainder of the time, just like the first panel, is going to be dedicated to some questions that will be posed of all of the panelists as a group, as well as an opportunity for some individual Q&A and discussion from the audience. So I thank you all for joining us here. You should have within your informational materials bio sketches for each of the panelists, and so I'm not going to do a formal introduction of them because they have all done such amazing work that would take our full panel time. So you can trust us that they're wonderful and then read more about them in their panel sketches. But we're going to go ahead and begin now with the individual highlights of their work. We're going to be starting with our first panelist, Anthony Biglan from the Oregon Research Institute. Tony?
Thank you. My name is Tony Biglan. I'm a senior scientist at Oregon Research Institute, which is not exactly boots on the ground when it comes to this. However, we rent space to the local coordinated care organization, and we have been, so we're their landlord. And we have been working with them for the last couple years on their efforts to integrate. The healthcare transformation started in Oregon back in the 1990s when, under the leadership of John Kitzhaber, we created the Oregon Health Plan and a system which took Medicaid funds and changed the procedures such that poorer people who were under 65 would have access to Medicaid. And that system has increased the number of people who are covered. But that has evolved under the leadership of Governor Kitzhaber, who was governor for 8 years and then was out of office and then was reelected and as you probably know, recently resigned. And I think that was a tragic situation. But they created the coordinated care organization system such that every county, or in sometimes sets of counties, had a coordinated care organization that would be the health insurer, if you will, for people on the Oregon Health Plan. And we've now got about 26% of the population, about 1 million people in Oregon, who are covered by the Oregon Health Plan. But the coordinated care organizations are also trying to significantly improve the integration of primary care and behavioral health, and they have the some resources to do that. So for example, in Lane County, which is where I live, the coordinated care organization is funding prevention efforts in the community, and it's funding clinics to integrate behavioral health and primary care. So that's one of the things I can talk about, but I'll ask you to prompt me if I talk too much. The other thing that I'm working on is I have a small grant from NIDA where we're studying the hubs, which are the, also under Governor Kitzhaber's leadership. About 6 years ago, they created the Early Learning Council in Oregon, and they looked at all of the things that are needed for young children to develop successfully. And what Dr. Halfon talked about is just so well aligned with the thinking of the Early Learning Council. That, through legislative action, morphed into the Early Learning Division, which is in the Department of Education. And the Early Learning Division is funding what they call hubs in counties, and sometimes multiple counties have one hub. And those hubs have the responsibility for improving the developmental support for young children. And I think it's very much what the kind of thing that Dr. Halfon is calling for, because it's a recognition that it's not simply a matter of the healthcare system doing a better job, but of having a community-wide effort to improve development for young children from the prenatal period through at least age 5. They have now, the Early Learning Division has now funded these hubs, and the first 6 that they funded were ones where there had been a fair amount of community development about what young children need, and they succeeded in competing for funds, and they funded them to focus on 3 outcomes. First of all, the children are ready to learn by the time they reach kindergarten, or ready for kindergarten, both socially and academically. The second, that families are stable and attached, and the third, that services are coordinated and efficient. And so what we're in the process of doing is interviewing the leaderships of those hubs. And there's a requirement that the hubs be coordinated with the coordinated care organizations. And I'm not sure how much more I should say at this point. There are a couple more things I want to get at, but.
If you can take another minute, and then you can touch on those during the Q&A. So
here are the issues that the hubs are having to deal with, and the CCOs. So, okay, now every child, virtually every young child who's in a poor family, which, as you pointed out, is a lot of families, especially in Oregon, though every child now has health coverage. Okay, well, the next question is, do they have a medical home? And so, you know, it's a developmental system. Okay, now we're going to get more and more in a primary care, in a medical home. Well, that's good. Okay, they've got a medical home. Well, the next question is, are they getting the developmental screenings that they should be having at the appropriate points? And so that's another one that you have to work on. Well, okay, as we get better at that, and we're certainly not there yet, as we get better at that, then we identify things that these children need. Oh, well, is there someone who can provide those? And so what is beautiful about the systems that are being developed in Oregon is that everybody understands what is needed and are working toward these and are clear about them. But then, you know, solving some of these is still a considerable challenge. And the most important, or the most difficult one in my experience is, okay, this child needs these interventions. Okay, is there a integrated behavioral health in that primary care setting that can provide that? For the most part, the answer is no. But whether there is or there isn't, is that child being referred to some services? And if they're referred, do they get those services? So this is a sort of infrastructure that is evolving. and I think to me is very impressive, and there's a lot left to be said.
Tony, thank you so very much. Next, we're going to be hearing from Gregory Hagan from the Cambridge Health Alliance.
Good morning, everyone. Thank you for having me. I'm a general pediatrician at the Cambridge Health Alliance. I work in a community health center in Cambridge, right near Kendall Square, which people now associate with very high-end pharma and technology, but there's still actually folks, housing projects, and folks who are quite disadvantaged right in the neighborhood, and those are my people. Certainly. Geez, I've almost never, no one has almost ever told me that I had to talk louder. But please give me feedback. I'm struck by listening today, the metaphor of boots on the ground is interesting and challenging because there's a lot of ground, a lot of systems, and a lot of different territory that's going to need very significant attention if we're going to reach the goals that were so well outlined at the beginning of the morning. I've been involved in, over the last 10 years, I'd say in 3 areas that are perhaps relevant to this boots on the ground idea. First of all, the Cambridge Health Alliance is a fairly large, the last freestanding public safety net entity in Massachusetts with 15 ambulatory health centers, 2 community hospitals, 4 school-based clinics, and a variety of other types of presence in the community. It's a wonderful organization. It's large and unwieldy. And in the Cambridge Health Alliance, over the last few years, there's been an enormous amount of effort to integrate in a real substantive way mental health services in the primary care setting. But as someone noted at during the last panel, virtually all the bandwidth was for adults. Virtually all of the bandwidth was for adults. In fact, I've been trying for the last couple of years to get the attention of the folks. It's a wonderful organization. The people are well-intended, but it's really hard to get their attention when it comes to the needs of children and families. And I'm actually pretty pleased that our state Medicaid program is rolling out a very robust primary care payment reform initiative, which is putting my organization's feet to the fire. So now, in the last 6 months, I've had the opportunity to work very closely with my mental health colleagues in the Cambridge Health Alliance, and we're putting together a model that we will be rolling out, I hope, over the next 12 to 18 months across our entire system. In addition to that, I had the good fortune over the last few years to participate in a small way with the Massachusetts CHIPRA Quality Grant Project. And that's relevant in 2 ways here. One is that we were, part of our charge from CMS was to evaluate these measures that we're talking about and to see, of the validated measures that are in the literature, which ones really seem to be most useful in real practice and real practice settings. I'm not sure we can answer those questions yet, but I know there are people who are working on putting that data together, and that will be known soon. The other part of that initiative was a large collaborative effort to bring medical home transformation to 17 very diverse practices across the Commonwealth of Massachusetts, private practices, neighborhood health centers, academic practices. And much of what was done, many of those measures, of course, these measures that we're talking about are generally process measures, not outcomes measures. And many of the measures that we had were sort of the conventional composite measures, excuse me, conventional composite measures of well child care, but nested in all of those were measures that are related to child behavioral health development. Finally, I've had the good fortune over the last several years to be working in my own clinic, in my own practice, on a project funded generously by the Blue Cross Blue Shield Foundation of Massachusetts to try to develop an actual working model of collaborative practice within my pediatric pediatrics practice. We have a child psychiatrist and a child psychiatry fellow who come and spend 2 afternoons a week. They're not just co-located, they are fully integrated into the team. And we are very excited about how the model is working and have had some pretty good results to share.
Okay, thank you very much. We've heard about wonderful work happening on each of the coasts. Now we're going to move to the center of the country.
A great flyover.
We will have Kelly Kelleher talking about the Nationwide Children's Hospital.
Good morning. I'm Kelly Kelleher. I'm a pediatrician at Nationwide Children's and Ohio State University. I'm here, I think, today to talk about our pediatric accountable care organization entitled Partners for Kids. Partners for Kids is a fully capitated, at-risk organization of 800 and some odd clinicians, primary care physicians, specialists, and the hospital, PHO, it's a pediatric physician hospital organization, serving 324,000 now Medicaid children and a growing number of commercial lives in an accountable care format. So we're fully at risk for behavioral health as well. And my argument here today is that after, as I've already mentioned to several of the forum members, that unless this is a good business argument, we should stop relying on the good intentions of policymakers and politicians to make child well-being a priority. And I think we do have some good business opportunities, but we have to figure them out. And they're very challenging, but they are there. When you take on full capitation risk for a large population across a large region, you learn several things. And there are three specific things I would highlight this morning. One is provider change. None of the 10 agencies admitting children for psychiatric problems, none of the school-based clinics, none of the individual mental health providers knew what the other ones were doing when we took on risk for those providers. So just putting providers in touch with each other dramatically altered the readmission rate for children, behavioral health problems, changed the number of referral pathways, and linked people better with care. Number two, so provider integration is going to be essential, and mom and pop shops for mental health are over and done with. And we should be clear about that to all of our training programs and to all of our universities and to everybody that thinks they can still hang up a shingle by themselves. Secondly, besides the provider, data and metrics become driving forces. And so all of a sudden you have to integrate data. This morning I found out that South High School, the largest high school near the hospital where we work, had 6,500 days of kids absent last year because of juvenile justice. And so just one school, that many days absent, that's a mental health crisis. And that's the school closest to the hospital. So when you start to look at data, you suddenly find where the emergencies are and where you should focus your priorities. And so we have had to find, we have 3 sets of metrics. We have metrics that are demanded by NCQA and HEDIS and state Medicaid agency and all those things that are very light and fluffy and up at the claims level. And those are looking under the lamppost, and we have to do that, and we should. But we also have to get a hold of the school data and get a hold of the foster care data and get a hold of the juvenile justice data and do the right thing. And we have to find out how to do that. And it takes a while. And fortunately, there's nobody racing ahead of us to do it, so we can take our time. But we have to figure out what metrics we can and cannot change in that regard. And there are ways to do things. And then we have a set of metrics that are internal and kept mostly inside the hospital that we actually work on a neighborhood program where we actually try to work on unemployment, school readiness, high school graduation, teen pregnancy, and some things that are outside our usual domain. And these are very difficult lessons for our physicians, our nursing staff, our administrators to learn. But once they get engaged, they actually get excited about it. And they want to do the right thing because they know these are the things that are preventing good medical care from being delivered to families. So they're willing to get engaged once they learn about it. The last specific thing is prevention suddenly becomes important. When 1/3 of all your pharmacy costs are devoted to behavioral health drugs, and it's the fastest growing area, when the highest readmission rate of all your major conditions is behavioral health, when behavioral health concerns are number one on all your community doctors' list, you suddenly say, gosh, we better pay attention to this. And you realize you can't hire enough psychiatrists, enough psychiatric nurse practitioners, and enough specialists to do this. So there's a real commitment now to prevention programs. Right now, and we've embraced a few specific programs because of the combination of cost and efficacy and effectiveness. So good behavior game, for example, with the schools is extremely popular because it reduces disciplinary problems in the classroom. It allows the schools to suddenly say, wow, we're getting great attendance, we're getting parents involved, we're getting teachers involved, and teachers are happier, and we have better teacher retention. So the schools are happy with us, but we're also seeing lower behavioral health referrals from those schools and better clinician interaction. So it's a two-way win. So things like good behavior game, this year we're in 100 classrooms. We hope to be in 500 in the next 2 years. The growth, though, has to happen across the board. It can't just be with the young kids. So we also need to have adolescent-ish programs. And with adolescents, we're really focused on technology because we can't figure out a way to disseminate to the rural areas fast enough. So we have a lot of people who don't have access, so we have several pilot programs. And all the pilot programs involve connecting people to both a real person and an online support program that they can work through together. And because we've tried them just by technology and just by a professional, and neither one of those models captures most of our teenagers. So I don't have a one solution fits all, but right now we're funding most of this through cost savings. And we have to be very specific about measuring our cost savings in all our programs now. We always want to talk about measuring the children, but if we don't measure our savings, then we can't show how that is going to make the business argument for these programs going forward.
Thank you very much, and very, very good to hear about an example of looking at making the business case for an investment in prevention and whole health. And finally, we're going to be hearing from Lori Stark of the Cincinnati Children's Hospital Medical Center. Lori?
Thank you. I'm Lori Stark. I'm the Division Director of Behavioral Medicine and Clinical Psychology at Cincinnati Children's. When I was hired in 1998, there were 4 psychologists at Cincinnati Children's, and I think my business plan called for adding 3 more. Today, we're up to about 72. I think we have a couple of models of how we've grown and provided service to children that may be informative in the discussion of the ACO. Many of our services are for kids with chronic illness and in those chronic illness teams, so in pediatric psychology. One of the areas that changed in 2002 was the way you could bill for those services. So health and behavior codes came on, which allowed psychologists to bill on the medical side and to bill for medical diagnosis where the health and behavior concerns were either the result of that medical illness or impinging on that. I think that really transformed the way we could integrate with medical teams for several reasons. We no longer had to get advanced authorization, so that takes out a lot of time and a lot of cost in getting that. So we were free to co-locate and integrate fully with our medical teams, and we have psychologists as part of almost all of our medical teams for those kids with chronic illness, including cystic fibrosis, headache, pain, oncology, transplant services, those types of things. What our psychologists do there is they, along with the medical team, see the patient. So you have the medical team, whether that's the physician, the nurse, and then the psychologist, and we integrate what we do. So often it's lifestyle change to either be more adherent to your treatment, or it's how do you cope. In our new onset epilepsy clinic, a psychologist is part of the team that follows the kids right after they're diagnosed, so their first new onset clinic visit. Those kids are at a higher risk for depression and anxiety, so we also screen. We identify the kids. And not only do we screen, but we don't just refer. Those psychologists can then give advice to the parents right there that may be enough. So in that 15-minute visit, the health and behavior codes also allow us to bill in 15-minute increments. So we don't have to see you for 45 minutes, which is what the mental health codes, force you into. So it may be that we can give parents some simple advice right there on how to handle burgeoning anxiety disorder that they can then take home and do and not need any other further services or follow-up until they come back in for their next epilepsy visit in 3 to 4 months. Sometimes we uncover kids who need more services. By meeting the psychologist in that clinic, they're much more willing to not have that stigma and maybe come to the psychologist's office for more frequent follow-ups if that's needed. I think this is a good model for how we might want to do prevention and early intervention in the pediatric practice, where you're co-located, you see every child as they come in. Right now, under the current system, that's not possible, but we have done some innovative things in how we partner with pediatricians. So ADHD is one of the most prevalent behavioral health concerns that come to pediatricians' offices. Sometimes they're overwhelmed. We began what we called the ADHD Collaborative, I don't know, maybe that was 8 or 10 years ago. And that came out of the community, pediatricians saying, you've got to help us with this. And we pulled together psychiatry, psychology, developmental disabilities, neurology, pediatricians, and parents to say, what's the best approach to this? Probably the most logical at that time was to, let's build a clinic. You know, we need more capacity to see these kids by psychologists or psychiatrists, but we really didn't feel that would answer the question or really help the pediatricians. At the same time, the AAP had come out with the evidence-based guidelines for pediatricians diagnosing and treating kids with ADHD. So we felt to add capacity, we should partner with our community pediatricians, help them integrate these guidelines into their practice. And so using support from the Anderson Center, we did a quality improvement initiative where we went out and worked with the practices so they would develop a system for how they're going to diagnose and integrate the Vanderbilts, because those are free and evidence-based, into diagnosing and how they're going to monitor that. Because at Cincinnati Children's, we're very tied to having our research and our clinical work together. We recruited a very good researcher, Jeff Epstein, and he was working on the same issue. He had developed what we call the ADHD portal, and he has subsequently improved upon that so that pediatricians can use this portal to send out Vanderbilts electronically to parents and teachers. They can set the timing. It will come back and it will give an algorithm that helps the pediatricians interpret that and score it, and then also do medication titration and management. In that, he's added an evaluation piece. So pediatricians can look at their performance on both the process, am I doing the evidence-based diagnosis and treatment, and also on their children's outcome based on the Vanderbilt systems, both within their patients, across their practice, and then across any of the pediatricians blindly that are using this system. So that's helped drive that. And right now we're partnering with Kelleher at Nationwide to do a randomized clinical trial to look at what are the kid outcomes. So we've already demonstrated that you can change pediatric practice, and then what's the outcome on kids. So those are some of the aspects that we're doing. On the prevention community side, we're partnered with Every Child Succeeds, and Bob Ammerman in our division is their scientific director. He has looked at, you know, not only prevention and what can we do for the kids, but what's missing for those families. And maternal depression is certainly a big driver, and he's developed Moving Beyond Depression, which many states are like now contacting Bob to say, how do we teach our home visitors that? How do we get this out for maternal depression? And I think many of these things can be used, and it gives a model of how we can do it in primary care. One of the questions that came up in the earlier panel was, what about outcomes? And what we found is our outcomes have to be meaningful to the clinicians and to the patients. If it's not, it's just data collection. So as we were going through some of our improvement work with our different disorders, pediatric pain, for example, we really asked our providers, what's the most meaningful metric that we make a difference on? And our psychologist said, where we really help is getting kids back to being functional, getting them to do the work of being a child, going to school, being social, doing those aspects. So our outcome is the Functional Disability Index, which shows as kids get more functional, their disability goes down. We collect data at every patient visit, and we share that data on Epic with our families. We actually show them the screen. We say, this is how we'll know when you're getting better. It takes the mystery out of that. And as they recommend cognitive restructuring for some of those catastrophic thoughts around pain, exercise, as well as relaxation, they can show the kids the progress they're making. We know that it's shortened our length of treatment because they can see it, we're working toward the same thing. We've also published papers out of these, so our research is very integrated with our clinical work. And from all of our clinical patients, they've shown it's always the chicken and the egg with a pain symptoms, right? What comes first? Do you get rid of the pain and then they'll get functional, or do you get them to work through the pain and they become more functional? Our clinical data would indicate what improves first is functioning. Once we get the kids out there functioning, their pain follows. So those are some of the things that we've been doing at Cincinnati Children's within psychology that we hope to spread as we partner with our effort in our SP 2020 to improve community health and integrate that with primary care.
Wonderful. Thank you so very much. And as Fan had noted during the first panel, there is a unifying question that's being asked of all of the panelists throughout the day and a half. And so I'm going to toss that common question out to members of this panel who might wish to respond. And that's that given the ACA specifically, or health reform more broadly, from your perspective, what are some of the biggest changes that have brought about the greatest opportunities to be able to prevent risk or to intervene when necessary to promote positive behavioral health for children and families, whether this is incentive structures or payment options or technology? Any thoughts folks on the panel want to respond to?
Well, from my perspective, the creation of the coordinated care organizations and the charge that they have to deal with the health of the entire population and the encouragement that they have to do that in all of the ways that could affect that health, and not simply they're showing up at a pediatrician's office and they're getting treatment, has created an infrastructure within which we can evolve, better and better practices. And I think the hubs are very important in that as well. The recognition that an enormous proportion of the variance in the development of children, including not only their psychological and behavioral health, but their physical health, is a question of what developmental supports they have, the family interventions or family supports that are available. I didn't mention before the quality of preschools. All of the hubs have developed plans to essentially improve the quality of preschool education and increase the proportion of children who have that. And so as they make progress on that, and by the way, every county is now going to have measures of the readiness of kids in kindergarten, both their social and cognitive readiness in kindergarten. And so and in Lane County, where I live, we've had this for about the last 7 years. So we have a chart on the wall in the community of the percent of kids who are ready. And in high poverty neighborhoods in Lane County, it's been about 50% that aren't ready. We should begin to see those numbers go down year after year, and we have good measures of that. So I'm fairly optimistic that we've laid the groundwork and have clarity about what is needed. And I think one of the things that's very important in that is simply a common understanding of what children need to develop, which I think has only really come together and become more widely known over the last 10 years.
Great, thank you. Other members of the panel?
As alluded to earlier, in Massachusetts, the state Medicaid program has taken a lead from the ACA to put into effect over the next 3 years a very ambitious plan to essentially shift all Medicaid patients to fully capitated, shared risk, actually fully owned risk model. It's rolling out initially with people being able to sign up for limited amounts of risk, but the idea is that over time it will be fully capitated. To their credit, they have required that that mental health care and developmental care be included in many aspects. It's not clear to me that it's as comprehensive as it should be, but it's a very good start. But as you can imagine, there are some challenges, and the first one that came up right out of the box was that they really didn't have very good data to figure out what the expenses were, and they really didn't have very good data to figure out how to set the rates. And guess what? This was particularly problematic for behavioral health. And initially, as folks sign up for this program, it is not mandatory that you take on mental health as part of your shared risk. And surprisingly, there are organizations in Massachusetts that you would think would be very well positioned to take that on. And in fact, the Cambridge Health Alliance is one of those entities which should be very well positioned to take on managing the behavioral health risk as well as the medical risk. And we politely declined so far because we just don't know that the numbers will support it. But it's a work in progress.
We'll be interested to watch that as that continues to unfold. Yeah, Kelly.
I think there are 2 or 3 specific things the ACA has done for us that haven't been mentioned yet. I concur with all the other ones. One is that it's changed the language for non-providers. So we have people in businesses talking now, our commercial large enterprises in Columbus, Ohio. There are several Fortune 500 companies located there talking about population health and prevention, which has never happened before in the benefits conversations there. So we have the state Medicaid director and the governor asking, well, what we want to have, do we need a population health director? Or do we need, they're asking questions about the language that have really changed the dynamic in that regard and allow this conversation about wellness and child development to enter in for the first time. I think they also, the other thing that it allows is the governor for the first time is talking about a children's council and integrating, so he's already brought in the kids with disability into the kids with Medicaid and capitation. Foster care kids are on the table in the discussion right now, and juvenile justice is next. So understanding that the risks, the dollars have to follow the risk pool, and that if he's seen positive results in one area, and the second area looks promising, now the third area is being teed up. So there's this cascade phenomenon, and it only is possible not with individual program grants and not with individual awards or a specific federal agency making a new kind of grant available, but it's only possible when there's an accountability for outcomes and there's flexibility in how funds are spent locally, because each local environment is going to be different in who's the right provider or who's the right payer or who's the right partner. And they have brought, you have to have all the payers on board, so there's a single set of incentives. I mean, one of the important things we have in southeastern Ohio, for example, in these rural areas, is they have 5 different Medicaid managed care plans. But if we can go in as the single pediatric ACO and say, this is your one protocol for asthma, this is your one protocol for your pay for performance, this is your one protocol for, they're not getting 5 different protocols for every single thing. And if the commercial insurers are also lined up, then it all becomes uniform. It becomes a singular pediatric wellness network rather than 25 different insurance plans, each with their own, punitive measures on your performance.
Great, thank you. Lori?
So I think Kelly hit what's happening at the state level in Ohio. I think that the ACO has also sort of changed the way organizations look at it. So I think Cincinnati Children's has always had a strong commitment to their community, but it's making us think about that interaction differently and thinking, how do we go beyond and outside of our walls, and what space do we occupy? So how do we partner with community agencies, with community churches, those things, and how do we deliver care that goes beyond our walls? And that's something that we're grappling with as we look at our strategic plan for 2020, but it's certainly made it into one of the pillars that community health is up front and center for us.
Okay, great, thank you. And I'm going to ask one final question for our panelists, and then we're going to take questions from the audience. So if people want to start lining up at the microphones in case you have any questions for any of the panelists. And so my next question is that there are going to be policymakers either in the room here today or in the audience watching this online that are going to be interested in the how-tos of initiating efforts in their area that are similar to some of the activities that you've talked about in your areas. So from a policy standpoint then, what were some of the key issues and the associated action steps that had to be taken in order to bring to fruition the type of innovative activities that you've discussed here today?
Well, I would argue that the basic policies that are needed for healthcare transformation are more or less in place in Oregon. I've described the coordinated care organizations, the hubs, and so on. But I think that the policies that the larger context for this that goes outside of the healthcare system as it has traditionally existed need to be attended to. You were talking about the kids who were in juvenile justice. I just attended a meeting last week of the Youth Transition Funders Group, which is a consortium of foundations that are trying to improve the transitions out of juvenile justice and foster care, because when kids are out of juvenile justice or foster care, they get out of foster care, they're 19 years old, they're out on the street, they don't have health insurance, they don't have family, and so they're really trying to improve those. The juvenile justice system is a stressor. It's a stressor for those kids, it's a stressor for their families. You talked about all of the different kinds of stressors. Many of them have to do with the interactions that poorer people are having with all kinds of service providers and legal people and so on. We've got to change all of that. And when you go outside of, and the larger context for that is a level of economic inequality and poverty that's unparalleled among developed nations. And so those are the larger social system contexts that we have to affect. And I don't know that there are any people here who are, you know, I mean, we're talking among ourselves in a certain sense, and we have to get beyond that.
Very good points. Thank you. Yeah.
I think one of the things is policy is important, but even when you have policies or regulations in place that enable you to do things, it doesn't automatically happen. So I had mentioned the advent of the health and behavior codes. Just because those were approved didn't mean anyone was going to pay them or understood them on the insurer side. So it took us a number of years, and if I did not have the support of the leadership at Cincinnati Children's, it would have fallen by the wayside. I'm often asked to go and consult with other behavioral health organizations and children's hospitals, and when we approach them about using those codes, most hospitals will not even try it. They won't try it because they say, oh, we won't get paid. We won't do that. So I think not only do we need the policies, but we need the leadership and the vision within our own organizations to push for implementing those policies as we've written them. So if we, win that battle of getting the policies, we still will have to fight the battle for people interpreting them and implementing them, and that's not always easy. So oftentimes behavioral health is not well reimbursed because in many institutions, they don't think it's worth going through all the hassle of getting it paid and reimbursed. Oftentimes you get denials for no reasons. Even though we're paid for the health and behavior codes, every once in a while, in the insurance companies, someone will look at the medical list of providers, and you have to be loaded there as a Ph.D. to get paid, and they'll go, oh, what are the Ph.D.s doing on them? And they'll hit the button and delete us. What took us 6 months to build, in 2 seconds is gone. We then have to go through another 6 to 1 year process of getting back reinstated. If I didn't have the support of my institution to do that, to track those claims and to have those discussions every single day, we would not get paid. So I think knowing that it's not only policy, but it's sort of those boots on the ground and it's fighting the good fight every day to have those policies recognized and followed.
Very good point of needing the leadership to support the promulgation and the following of those policies. Thank you. Gregory.
So in Massachusetts, we're a fairly liberal state, and there are lots of very well-intended people, and we have Romney Care, so you'd think, geez, this shouldn't be a problem. But we still have the problem that services are directed disproportionately towards the needs of adults and not towards children and adolescents. And we've been trying to work on that, and I think I've made some real progress in the last several years. And I think it goes back, what my strategy has been, and what I've been working with other folks on is to take the information that I think everyone in this room knows about early childhood and brain development, about toxic stress, and about the critical role that those are going to play in determining our social capital, and use that information, focus on that information like a laser beam. And we initiated, the Massachusetts chapter of the American Academy of Pediatrics initiated a summit on early childhood about 5 years ago, brought in stakeholders from many, many disciplines. It was pretty successful. The second one was about 2 years ago. Building on that, we had the chairman of the Boston Federal Reserve, we had the governor, we had the heads of Akamai Technologies and several other tech firms there. These folks all really understand the social capital issue. They really understand the need for kids coming out of schools who have competencies in the STEM areas, science, technology, engineering, and mathematics. And if you focus on that in your advocacy, that's where I think you begin to get traction with the well-intended folks who may not really think about this stuff very often, but who can make a big difference when it comes to moving the policy agenda in your state.
Thank you.
Yeah, I just want to extend Greg's comments one little bit. So Greg's one of the nice guys. There's a reason I went into pediatrics, because he's really straightforward and really got the good fight going. But I also think we have to fight dirty. And I mean, you know, oh, gosh. That's right. You know, the pediatricians and the child psychologists and the developmental people are all such nice people. And everybody went in to help save the babies. And saving the babies doesn't get us at the table a lot of the times. So I think we have to call the governor and call on those people. But I think we have to have the public forum meetings, but we have to have individual meetings. We have to have private meetings and find the soft spot of every one of these people and find out what their win-win is and where they see. Because almost all of them have a personal story. And almost all of them have something they really care about. And almost all of them have a company that has a problem that they want solved, and you can help solve it. But you have to do your homework, and you have to have those private meetings so that when the public meeting happens, they all raise their hands at the right time. So I think there's a lot of trying to learn about what they value, and the same is true with our big superintendent, you know, state superintendents of schools and the state prison boards and other people. They each have a soft spot, and we have to find it, and we have to apply pressure in a positive way, because we're positive people, but it's still got to be for the kids, and we have to fight with the same tactics everybody else uses.
Excellent points. I think, as Dr. Haflon said in the opening, we need to be more audacious. So I like your reiteration of that. So we'll go ahead now and take some questions from the audience. We'll go until about 12:07 and then break for lunch. So over here.
Yeah, well, thank you. I'm Sheb Kellum from Hopkins School of Public Health. My point is to argue strongly for moving schools and education into healthcare and make it one thing over a life course system based in community political support and at various levels from the community through the city, Chicago, for example, and beyond. My father was in the grocery business, and he was very interested in having customers come to his grocery store. He didn't know who didn't come. Primary care is a grocery business model. The people who come have an opportunity to, in fact, be served. The people who aren't there are unknown, and there's no overlap from one grocery store to another because they're in competition. So we need to get a catchment area kind of model and then move these grocery stores into a system. And in order to do that, we need to take a look at what the information is that's already being collected by schools. Well, there are things like what the pediatrician would call attention deficit, hyperactivity, and so on, various DSM categories, what the teacher would call a kid who's impossible to teach and disrupts the classroom. Well, it turns out teachers themselves get no training in how to deal with the children who are aggressive, disruptive, and not yet ready developmentally to learn. And without that, and the teacher is facing a child who really does have developmental delays, attention, you get a combination that's lethal for the classroom, not just for the child, but the teacher's burnout rate is intimately related to the inability to manage classrooms. And they get little or no training in their training to be teachers. So we have to be concerned with building an integrated system over the life course that involves health and education, schooling, and involves other agencies as needed. And the information system that the school already has under conditions of oversight that are traditional in schools. The school district controls, but out of mutual self-interest, they could be made to understand the useful collaboration around the right to know certain kinds of information that they could share for purposes of child development and teacher survival. So we need an integrated system. It follows very much on Dr. Helfand's comments. I was sitting here fantasizing, are there any educational scientists or educators here who are in charge of school districts? Just out of curiosity, would you raise your hand? Let me tell you, this is typical. There are a lot of people thinking around how to integrate and make systems, but when you go to scientific meetings or policy meetings, there's very little overlap. And we create information systems separately, and they're expensive, and they're not very effective if they're not integrated with a right to know kind of oversight.
Well, Kelly was mentioning the implementation of the good behavior game, which is happening quite a bit in Ohio, and it's also happening in Oregon. You may have heard of the good behavior game, Shep. He was my professor. Well, Dennis Embry is.
Those are all very good points. Thank you very much. And yeah, I mean, this is one of the things that the forum does also discuss are opportunities for linkages across different sectors, different areas of focus during upcoming sessions, different partners to bring to the table. And so I thank you too for emphasizing that. Do we have a question over here?
Yeah, thank you, Dr. Kellum, for those comments. I'll follow up with that with as you for your programs that make mental health services more accessible to kids, you have improvements, and I think it's really important to look at the improvements in the child behavior as it impacts school variables. If the schools see higher graduation rates, higher test scores, better school attendance, then they're going to be on board. So it's very important when we talk about integration across sectors that we look at the variables that are important to the integration partners. They might not be health variables. And then a second point for the mental health professionals, I was involved in a program in Delaware which had positive behavior support. They don't do good behavior game in Delaware, they do positive behavior support. So a big improvement in behavior, and then another group came through and did the 30 minutes of physical activity a day, make school a moving experience, and improvement in school lunches. And over the span of 2 years, we saw another shift in improvement in behavior. So it just pointed, and I was very skeptical when they started as a psychologist that this would have any impact. But the point that Dr. Halfon made earlier today, that you've got to look at all those variables, and we as mental health professionals in particular have to be aware of the other things that impact kids. And again, those get some traction and get some support when you show that it affects the variables, attendance, test scores, special ed referrals that are important to schools.
Anyone want to comment?
I would just say the schools actually don't let you in if you don't have variables that are relevant to them a lot of the times. And it's actually one of the biggest challenges for us is we're serving 34 counties, and there are basically 125 school districts. And we have to go into each district and at a time and say, wow, it's okay to share your data. We promise to take care, and oh no, we've never shared our data. Or here's your health data. We're actually offering the school nurses the opportunity to be providers and view the child's medical record for children with complex conditions in the schools as a provider. And the schools are saying, no, we don't want it, because we're afraid if we look at it, then we might have some responsibility.
That's curious, because we had the opposite experience in Delaware. The schools have really took up the...
We've actually tried to learn from the Delaware, so now we're trying to get guidance from the state towards them to do that. So I completely concur. But it's a learning experience going when there's 120 some odd districts. Each district has their own personality, and it's been challenging.
Thank you. Over here?
Costella Green, SAMHSA. I work in a division of community programs, and I just wonder, all of you talked about communities and your work with them. How are you working with community coalitions? Because I think your reach could be further or farther if you worked with the community coalitions. I mean, there is science now, and I think to get to your target of the communities that you want to reach, I just wondered if you all could comment on working with community coalitions.
I don't think that the hubs ever could have been developed except for the fact that they had already created coalitions in the communities. And so, for example, in Yamhill County, which is a relatively small county, you talk to them about what they're doing with early childhood, and they've got all of the players at the table. They have all the people who are traditionally involved in young children, but also broader than that, churches and economics. And in fact, the head of the CCO there has invited me up there to talk, because what he's now trying to do is get the business community to understand this. And I think that that's extremely important in terms of the economic implications of what we're doing.
No doubt that if we're going to be successful, we have to work in a very, very robust way with community organizations. We're very fortunate at the Cambridge Health Alliance in that Cambridge Health Alliance is also the City of Cambridge Department of Public Health, which has terrific relationships all across the city with various groups that inform everything that we do. And this is something that we've also replicated in the other cities that we serve. So it's just, I think it goes back to the idea of a health system 3.0. We have to break down these barriers, and the only way we're going to do that is if we are fully integrated with these community organizations.
So, Stella, I want to actually say that I wish it was just getting involved with the community organizations, but there are a million different community organizations, and they disagree with each other. So, in some very basic ways, if you get involved with the usual community health organizations in a lot of neighborhoods, the long-term homeowners dominate the civic associations and the homeowners consortiums and all of the standard groups that you might get involved with tend to be very insular in certain neighborhoods, and they're not including the young women and families with young children, and they're not, we don't see them at the meeting. So we've had to actually form different groups to get rental support, because they've always advocated for home improvements, not rental support and not emergency home aid. And so I think it's a challenge for a hospital to take on those skills, or a PHO or an ACO to learn new skills like that. And there's even things like we have the homeowners association, fighting us to buy property to close down adult bookstores near schools. And then when we do that, a lot of the young men that were working there lose their jobs, and then the unemployment rate goes up. So, it's not just an equal trade-off all the time. There are different communities that you're talking to, and there are different values.
So that said, I think it is important to know who the community leaders are and to be partnering with them. So with Every Child Succeeds, they have a strong partnership with the United Way, for example. last night I had dinner with Uma Kodakal, and she was talking about how our Board of Trustees did their meeting out in the community and actually invited speakers from the community in to provide that education about them. So I think it's important, but I've also heard the same thing that Kelly says, that not every agency is aligned in theirs. And so sometimes you're walking that tightrope of helping people come together for a common vision.
Okay, great. Well, I've learned that it's never a good idea to stand in between a large group of people and their lunch. And I know that we do have some more folks that are lined up for questions, but maybe if you all could approach the panelists as we're breaking, or perhaps to have the opportunity to chat with them over lunch, that would be good. And so we are breaking now. Food will be outside. And if everybody can just join me in thanking our wonderful panel for their insight.